He did not go with police.
Where did he go? Whoa.
Welcome, everyone. We're just letting folks trickle in before we get started.
Hi, everybody. I think we're going to get started. Can everybody hear me? Jason, I can see you. Okay, great. Thank you. I can see your face. Can you give me a thumbs up? Awesome. Thanks, everyone. I'm Mia Sorcinelli, and I am a MCSTAP consultant on Tuesday mornings, and I also am a family doctor. I work in Lawrence at the Greater Lawrence Family Health Center. And I am board certified in addiction medicine as well as family medicine. And I'm lucky enough to work in a methadone clinic 1 day a week also. So I'm going to talk a bit about methadone in general, and then methadone clinic a little bit. And then we'll talk some about QTC prolongation and kind of how to manage that without panicking. And so here are our learning objectives. So we'll briefly review just some data about opioid use disorder scope and some treatment stuff real quick. We'll glimpse inside the world of methadone clinics, because I think if you don't work in a methadone clinic, it can seem kind of mysterious. We'll talk a little bit about some of the literature that's out there and expert opinion guidance around QTC prolongation. And I'll talk about some common scenarios that can lead us to see these abnormal EKGs. It is pretty common. And then we'll talk about, my way of thinking about the risks and benefits of adjusting a methadone dose, or what else can we do versus, the risk of opiate use disorder worsening. Disclaimers. So I'm not a cardiologist. I'm a family doctor and an addiction med doctor. And so, some of the cases that I see, I don't know what to do with, and I ask for help. And I would encourage us, in particular, if we're in the hospital setting, but even in the outpatient setting, reach out for our colleagues in cardiology. And then another disclaimer, just, if I talk about methadone clinics, so I work for Spectrum Health Systems. They operate methadone clinics around the state, and I work at their site in Saugus, Massachusetts. So I'll talk a little bit about like federal rules and regulations, but I don't know how every single methadone clinic in the state works, right? I know my own clinic setting. And so this talk came about just so people know a little bit of the background. So at Greater Lawrence Family Health Center, we have a family medicine residency program. And during the pandemic, we lost the physician who was doing inpatient addiction medicine consultation. And so our residents would be seeing patients and they needed help with them. And so we have a very busy Zoom channel culture at my clinic. And we had this Zoom chat where people could ask us for advice, ask those of us who do a lot of addiction work. And we would get these Zooms from our residents and they would say, oh, we have a patient and their QTC is prolonged. I'm going to just cut their methadone dose in half. And we'd be like, wait, don't do it. Tell us more. So this is kind of what brought this talk about, because it was one of the most common questions that we kept on seeing over and over again from our residents and even from our attendings who didn't have a lot of experience with methadone. Like, oh my gosh, I have this abnormal thing and I feel like I need to do something and I'm panicking. I'm just going to slash their dose without really like pausing for a minute and thinking it through. So that is why we're doing this talk today, to help us all not panic. Okay, so I think we all know this, but I just went through and kind of updated some of the data. Here are the drug overdose deaths involving opioids in the United States. Over on the left-hand side is 2001. This is the most updated that I could find from the CDC. So 2021 still lagging a little behind real time, but we can see this curve is just very rapid up. And this dark blue here is synthetic opioids other than methadone. In Massachusetts, to me, this means fentanyl. I think we all know that fentanyl is huge in the communities. You can see the little light blue line is heroin. It's really going down. And so, I'm just reminding us all that the opioid epidemic is still in full force and still really poses a threat to life of our patients. And then, so that's national data. This is Massachusetts. And again, I believe that this is the most updated. So 2022, this is from the mass.gov current overdose data. It was updated in December of 2023. So, our numbers continue to climb. They're not quite as exponential looking as the national data, but 2022 had more overdose deaths than 2021, which had more than 2020, et cetera, et cetera. So we still could be doing better. And I'm assuming this audience knows this, but we're just going to quickly talk about the 3 medications that are approved by the FDA. So we're very lucky when we treat opioid use disorder. We have options to give people. So we have methadone. Methadone for treatment for opioid use disorder is only dispensed from an outpatient treatment program known as an OTP or a methadone clinic. I'm a PCP. I also work at a methadone clinic. I can't prescribe someone methadone in my PCP clinic right now, the way the laws are for opiate use disorder. I can only give them that methadone if they're coming to me in my other job at the methadone clinic, which is kind of funny, but there we are. Then we have buprenorphine. So, this is available in a bunch of different brand names. Suboxone, Zubsolv, Sublocade is the injectable. There's also Brixadi, which is another injectable. Subutex is the buprenorphine mono product. This is the one that PCPs should be offering and can be offering in clinic. It requires just a little bit of training, or really not even any training anymore. And then you can prescribe it in an office setting. And then we have naltrexone, which is brand name Vivitrol. That's the injectable version. That's also used for alcohol use disorder treatment. So just to remind us again, when I talk to patients all the time, I say, well, buprenorphine, it's kind of like a 50% opiate. And then we have methadone, which is like a full opiate. So methadone, is 100% active at the opioid receptor. It's a full agonist. It binds to that receptor. It's very long lasting. It has a long half-life. And then naltrexone, which is down here on the bottom, these little triangles, that's not an agonist at all. It has no effect aside from blocking the opioid receptor. So methadone has been around for a long time. It was developed actually in the lead up to World War II in Germany. So some patients will say to me, well, the Nazis invented methadone, and they're not entirely wrong, unfortunately. It is a very, very long-acting synthetic opiate. As I mentioned, it's a full agonist. And really, I would say even, during the golden era of buprenorphine, when it was such a great option and we didn't have fentanyl, I still love methadone. I still think for some patients, it's the most effective. When you look across the data and you look at treatment retention as a marker of efficacy, about 85% of patients stay in treatment. Some people, they kind of bounce in and out. Nowadays in the fentanyl era, if someone's struggling on buprenorphine, I'm really recommending to them over and over again that they consider methadone. Just stronger. It's easier to start than buprenorphine, and patients can take it the same day that they've used buprenorphine, and nothing bad will happen to them. The downside is that it's very strictly regulated by the federal government. Some of the strictness has been loosened. Some of that was a hidden blessing of the COVID pandemic. So a lot of the requirements around take-home doses, for example, were loosened during COVID to protect vulnerable patients from being in a methadone clinic every day. And now there's been a lot of changes at the federal level that went into effect on April 2nd that even further kind of loosened some of our restrictions in terms of dosing. And so that's great to see. There's been some change and some progress federally and in the state. But I would say it's still, for some patients, the necessity for at least some daily dosing and, presenting to the clinic, that can certainly be a barrier for patients. And as I mentioned at the beginning, when we're talking about methadone, we're talking about the methadone that's dispensed from the clinics. It's really separate from primary care. And so a lot of patients kind of, they're in this weird silo. We can't see the methadone that they're getting in the methadone clinic on the prescription monitoring program. And sometimes as a primary care doctor, you may not know that someone is on methadone. And as a methadone clinic doctor, when I always ask people, well, who's your primary care doctor? And some people will say, well, please don't call my doctor and tell me that I'm getting admitted to the clinic. And usually I say, well, if you can't tell your doctor that you're on methadone, you need to find a doctor that you can tell that you're on methadone. Because, it's important that we know these things about our patients as primary care doctors. So when I see people in the clinic, my methadone clinic has a same day admission process. So it takes a couple hours, but it's all done in one day. There's some sort of standardized intake that our admission team does with them, usually over the phone. And so, in Massachusetts, if any of you are part of an OBOT program and you have Suboxone patients that are enrolled through the state, that they have these enrollment and disenrollment forms. The methadone clinic forms are pretty similar. So they fill out all these forms. They do a nursing assessment. They get a drug screen. They get a COWS score. They do a breathalyzer. If they are a person who could be pregnant, they do a urine pregnancy test on that patient. There's some sort of assessment that I do as the program physician or the, if there's a nurse practitioner or PA. It's a focused HMP or HPI, to guide safety, eligibility, decision making. We ask a lot about how much they're currently using. We try to estimate their tolerance. And before April 2nd, the maximum dose that I could give somebody on the first day was 30 milligrams at one time. And then if they were in very severe opioid withdrawal, they could wait a little while and be reassessed and get an additional 10 milligrams. That was rare. So most people would get 30 milligrams on the first day. And then we would sort of increase their dose over a 10-day induction period. And generally they were getting up to about 60 milligrams, which is okay. It's not great. Some people still are substantially feeling withdrawal, and some people are still continuing to use quite a bit at that point. So now the rules have changed and we have a lot more flexibility about that first dose, as long as we're documenting our assessment of somebody's tolerance and their risk of, sedation or adverse effects from methadone, which is great. It's very exciting. Like the first patient that I wrote for a higher dose, I was all excited. I don't know if the patient fully understood my level of excitement, but I bring this up just so people are aware that getting to a stable dose of methadone, it doesn't happen overnight. It's not, a quick and easy process for patients. So there's some good evidence out there that says, if you're at 60 milligrams or higher, that increases your treatment retention. So, people who are poking along at these low doses, or they're missing multiple days and they can't really get to a steady dose, those folks are at risk of, falling off the clinic, of not being able to continue in the clinic. And then if you look sort of at everybody on methadone all across the country, the, quote unquote, average dose falls somewhere between 80 and 120 milligrams a day. And what that means is that for many people, if they're in that range, they will feel a lot better. They will feel, quote unquote, stable. They'll be able to do their activities of daily living. They will cut down substantially or completely stop their use of illicit substances. And just a reminder to us all, methadone, I mentioned this before, has this very, very long half-life. And so as we're increasing, and even when, once patients kind of get to a steady state, some of yesterday's methadone is still in your body today. And so in particular, if someone's frail or older, they've had trouble in the past, we're just being cautious. Like, we're assessing all of this as we're admitting people to the methadone clinic. Here is a picture of the steady state concentration of methadone. It takes a while, so it kind of goes up and down, and then they get to this point where, here's day 6. They're kind of finally at this point where their serum level still varies throughout the day. So the peak occurs about 4 hours after you take your dose. And then for most people, that trough is sort of right before they're getting dosed. And so it's up and down, but still within a better range than initially. So, methadone's a life-saving medication, right? We know this. If we're doing this work, if we're in this space, the disease of opiate use disorder, it's severe, it's life-threatening, patients die. Methadone, being in a methadone clinic has all these wonderful benefits. People decrease their IV drug use, they decrease their overall drug use, rates of HIV and Hep C go down, other illicit activities, sex work, theft, all that stuff decreases. And we also know that being in treatment longer is better than being in treatment for a shorter amount of time. So, there's data out there that says 2 years is the minimum. I know patients, they've been on methadone for, 20, 25 years, and they're like, hey, I'm never coming off the clinic. I'm just going to stay here because I know I'm safe. This slide is maybe a little hard to read, but this is from findtreatment.gov. And so I don't know where everybody's joining us from, but there are methadone clinics all across Massachusetts. You can use this resource to search for your local methadone clinic, the little pink dots are the methadone clinics. Methadone clinics are all across the country, actually, and they've recently started this thing where every patient is entered into a registry, and so every clinic can see every patient's dose, which is pretty cool. And then for like, this is something that comes up all the time and not everybody knows, there is this thing called guest dosing. So, if patients are traveling to Florida and they want to go to Disney World with their family, they can go to a clinic that's in Florida. It takes a little bit of paperwork, but it's pretty easy to do. And they can set up what's called guest dosing. Puerto Rico has methadone clinics. Dominican Republic does not. There's no guest dosing in the Dominican Republic. This is important for me. I work in Lawrence. And now the methadone clinic take-home policy is a lot more flexible. And so for some patients, if they're traveling, they don't even need to worry about guest dosing. They can just take their doses with them. So methadone's great. I hope I've convinced everybody of that. But, remember also that it has some serious adverse effects. So QT prolongation, which we're going to talk more about, torsade de pointes, which is sort of the next step along the QT prolongation, arrhythmia, VTAC, VFib, asystole at the worst. It can do some other strange things, anaphylaxis. I've never actually seen that. Some people are allergic to the dye in colored methadone, but I've never seen anybody actually allergic to the methadone. It can cause androgen deficiency. It can upset the hypothalamus and the pituitary axis and the thyroid. So just to be aware of those things. It's also metabolized, or it is metabolized by the cytochrome P450, the 3A4, and the 2B6, excuse me. And we know, if anyone's ever had a patient on methadone in the hospital or in clinic, it interacts with a lot of different substances. Benzos, for example, are metabolized by the same pathway, so they are synergistic. They increase the effect of each other. Phenobarbital actually decreases methadone levels. Erythromycin, Seroquel, Celexa, a million other medications. We don't have time to list them all. They can cause a prolonged QTC. So for those of us who are listening who are PCPs, I always say, to my residents when I'm working with them, if you have a patient on methadone, put it on the med list. And then at least I know we see a lot of pop-ups and we get tired of those pop-ups from our EMR, but at least it's on your med list and you can kind of remember, oh yeah, maybe I shouldn't give this patient, clarithromycin or whatever I'm thinking of giving them. And again, just a reminder, I said this before, but it does not show up in the PMP if you have a patient who gets it from a methadone clinic. If someone's prescribed methadone for pain, it does show up on the PMP, but not from the methadone clinic. So when we talk about QTC prolongation, what we measure, or what the machine measures, is the QT interval, and then the machine calculates out the QTC, which is corrected for the heart rate. And the literature and what I do is I look at the QTC rather than the QT, and that's more accurate because just the heart rate can affect it. I say in general, it's okay to trust the machine for this calculation. I don't spend a lot of time, with calipers measuring it out. Normal for men is sort of depends on what source you look at and who you ask, but 440 to 450, and then women is 460, 470. A lot of people, probably including me, I don't get that worried unless it's greater than 500. That's kind of my threshold to be a little more vigilant. If it's 478, would I, chat with the patient about it? Probably, but am I gonna, do anything? Not necessarily. Maybe I'll put a pop-up in the chart, but greater than 500, that's when I get a little more worried and start to think about doing something, making some kind of change. So, it's interesting. The pathophysiology of this is complicated. There are these, if we remember from med school, there are voltage gated potassium channels in the myocardium. And so they can have like prolonged action potentials, and that shows up on our EKG as a long QT or a QTC. And then interestingly enough, I didn't know this until I was preparing for this talk, methadone actually can interact directly with those channels. the voltage-gated potassium channels. And then there is a genetic component that people maybe have seen where there are some patients that are on no medications that prolong the QTC, and they just have this already, they have a familial component to it. And, why do we care? Ultimately, the reason that we care is because it can cause torsade de pointes, which can cause, sort of unexplained syncope. And if it continues for long enough, it can become unstable and cause VTAC and, rarely can lead to death. So as a methadone clinic physician, I take QTC prolongation pretty seriously, but I also try not to, panic about it. When I'm talking to patients, so when I'm doing admissions in the clinic and I'm trying to explain this to patients, because I'm not going to talk about the voltage-gated potassium channels, but I say methadone can sometimes cause a pause or a slowing of part of your heart rhythm. And then I wave my stethoscope at them and say, I can't hear it with my stethoscope and you don't feel it. Because a lot of patients will say to me, oh yeah, sometimes, my heart skips a beat. And I'm like, no, that's not what we're talking about. You really can't feel it. And I say the only way that we can monitor it is to get an EKG, and then I'll take a look at it and make sure that everything looks good. Some other risk factors. So I guess I should update my slide to be a little more politically correct here. Assigned female at birth is higher risk. Anytime someone has hypokalemia, higher dose methadone. So at my clinic, again, I don't know what other clinics are doing, but at my clinic, anybody who wants to increase above 125 milligrams, we do an EKG. There's been some studies that show that requiring an EKG on admission actually is sort of a barrier and doesn't really make anybody that much safer. Obviously, drug interactions, that's one of the most common things that I find when I talk with patients and review things. Underlying cardiac conditions, if someone's had, for example, severe endocarditis and they were really, really sick, there can be some underlying damage there that is hard to quantify, but can show up as a prolonged QTC. Unrecognized familial long QTC. And then there's some other DNA polymorphisms, again, that we're not we're not testing people for these. We're sort of finding them when we look for it. So I work in a community, federally funded community health center in our community hospital. So I was looking for some data that was similar to my patient population. This is a nice little study. It's from 2015. They looked at an inner city urban community in the Bronx that had a fairly large number of patients on methadone, and they went through and reviewed 291 patient charts. So they looked at telemetry records and all this different documentation, and they looked sort of for greater than 470 for men and greater than 480 for women, and that was considered prolonged. And so just of all comers showing up in the hospital on methadone, 25% had, met that definition of a prolonged QTC. So it's common, we will see this in the hospital setting. We will see it in clinic if our methadone clinic patients are coming to us in a primary care setting and asking for an EKG, we'll probably come across it. They also looked at this cutoff of greater than 500, and there were about 14% of all the encounters had a greater than 500. And only 3% actually had a real arrhythmia that was documented on telemetry. So that's overall reassuring. That means 97% or 96% of people, even though they had these prolonged QTCs, they did not have an arrhythmia. And they found that the dose-dependent relationship was maybe a little weaker than we've sort of all been taught. My teaching was that the higher dose, the more likely you are to have the increase. And the other thing that I think is really important is that they found that about 40% of patients were on at least one other QTC prolonging medication. And anybody with 2 or more drugs that interacted with methadone had the highest prevalence of QTC prolongation. So that was 29%. And again, I would say anecdotally, this seems very true to me when people, when I find an abnormal EKG and I go through their med list, usually they're on either, 1 or 2 or more meds that can affect the QTC. So I I mentioned this already. So in 2013, they did a Cochrane review and they kind of said there's not really enough evidence out there to say everyone needs an EKG before they start on methadone. And that then there's this other, article from 2017 that said that it's not clinically significantly related to the dose, and that cardiac events were rare, and sudden cardiac death of methadone patients was below the general population, which I think is really interesting. So we worry a lot about it. And I'm not saying we shouldn't, because I worry about it too. But I think you can feel reassured by the data that, in the end, as much as we hem and haw the real, the risk of death to our patients with opiate use disorder, they're probably more at risk from their opiate use at most, most of the time. All right, so so these are real, ripped from the headlines, real cases. A 37-year-old patient who has a 20-year history of opioid use disorder. She started using Percocet after wisdom teeth extracted and rapidly escalated to IV heroin use. She's been on 15 detoxes. She's had 7 overdoses, tried Suboxone twice and was not able to be successful with treatment, really struggled. And then somebody suggested to this patient that they should go to the methadone clinic. And since starting at the methadone clinic, the patient has been sober, has not used any opioids at all, has a job, and has a 1-year-old child and is parenting that child successfully. And their current dose is 140 milligrams a day. Oops. So I just want to pause and be like, yay, this patient is doing great. 3 years, no use on a methadone clinic. We feel good about this, right? Okay. So this patient has had 3 days of viral gastro. Maybe it's norovirus from the baby in daycare. We don't know. Presented to the ER because she wasn't able to tolerate any PO intake at all and was feeling very weak. Her heart rate was 100, her BP was a little soft, breathing a little fast, and her EKG was obtained. And sorry, these are real EKGs, so it's a little hard to read it, but her QTC is 492 and her QT is 466. And we didn't capture her tachycardia on this EKG, but we can pretend that it's there. And this is one of the EKGs that our lovable little residents working in the hospital would see and would go, we're admitting this patient. Oh my gosh, her QTC is prolonged. What do we do with her? She's on a crazy high dose of methadone. What do we do? And so I want to know, I don't know if people want to put it in the chat or if you want to unmute and tell me what you think you might want to do. And I think I have a little menu of choices here. Would we decrease her methadone dose by 50 milligrams? Would we decrease it by 10%? Would we do some more labs? Would we do nothing? How high is our blood pressure as the provider in this situation? Anybody? There's 30 people here. If nobody wants to shout it out, that's okay. All right, somebody, thank you for writing this in the chat. Kathleen wrote check electrolytes. Someone else wrote hydrate and recheck. I wouldn't decrease methadone for a QT of less than 500. You guys are awesome. You're my people here. Okay. So this also comes up from time to time before we get to the punchline of the story. What about IV methadone if the patient is vomiting? So, tuck it away in the back of your mind. There is such a thing as IV methadone. I would really, really reserve it for only the most serious situations where someone is absolutely not tolerating anything by mouth, because it contains chlorobutanol, and that also increases the risk of QT prolongation. So in this setting, with someone who already has this little bit of an iffy EKG, I would not rush to give them IV methadone. That wouldn't be my first choice, just a little learning point. So her potassium comes back, surprise, surprise, it's 3. And they give her some IV fluids and they give her some potassium in those IV fluids. And they repeat her EKG in 4 hours. And now her QTC is 430. And we breathe a sigh of relief because we did not panic and we didn't do anything crazy. And we kept her on her methadone. Yay. Okay. All right, case number 2. This one's a little more perhaps controversial. So this is a 67-year-old gentleman with a 20+ year history of opioid use disorder, has been on methadone for many years. His current dose is 80 milligrams. The patient feels well, not using. Patient has some history of coronary artery disease, a stent, smoker, some sort of, intellectual disability, and kind of poor insight into their overall health. Like they don't always understand how all these things interact. And, this is, I would say, a pretty common patient for us at the methadone clinic. This patient was seen at urgent care yesterday. They were given azithromycin and prednisone for their COPD exacerbation. And they come into the ER and they have, sort of this atypical chest pain. It's not really substernal, nobody's panicking about their chest pain yet. Their vital signs look pretty reasonable. They do an EKG. The first troponin comes back. It's normal. And sorry, this got cut off a little bit for some reason in the slide. It says 543, prolonged QT, abnormal EKG. What are we thinking now? Oh, I'm sorry. I'm going to keep going with the case. So the cardiologist calls in and says, oh, he's had a stent in the past. I think we should admit him and rule out an MI. Great. So now what do we do? You're the intern or you're the attending, you're writing their orders. They've already had their dose for the day. What should we do with their tomorrow methadone dose? And their QTC is 540. If people want to put it in the chat, I have the chat open. I can see, do you want to change it? Do you want to keep it the same? Should we repeat an EKG in the morning? Should we look at their other meds? Should we do nothing? You're going to get a call from nursing in the morning. Anybody? So I would say, remember what we know about methadone. It's very long lasting. Whether or not you alter their dose for tomorrow, it doesn't affect the fact that their methadone from today is in their body today. So some people think you are chiming in and saying at least check some electrolytes, right? At least do a medication reconciliation. The patient was given azithromycin in urgent care. Could I hold that and give them a different agent, perhaps for their COPD exacerbation? Great. So then the telemetry nurse calls a rapid response. And now this is what we see on the monitor. And this is torsades, right? So we see it's kind of the smaller amplitude, and then it gets bigger, and then it gets smaller. Now what? No, I can see one person's face. They're making a scared face. Yeah. This is a rare. So remember, our data says this only happens to about 3 or 4% of patients. But right in the moment, methadone is not factoring into our decision making, right? We're going to do the emergency things that we do when patients develop an abnormal. We're going to call a code. We'll get the rapid response team. We'll follow the ACLS algorithm. Maybe we'll shock the patient, save their life with electricity. If the patient is unstable, we're always going to follow the algorithms, and we'll just do what we do in this setting. We will consult cardiology and get them on board. If they're stable and they have this, so say this guy didn't do that thing where he went into torsades and he just has this prolonged QTC. I think that this is a good, if we're admitting them to the hospital anyways, it's very reasonable to keep this guy on a monitor. He has a cardiac history. He has an abnormal EKG. If he's, in the middle of the night, if he does a little blip of torsades and then comes back out of it, somebody will know about it, somebody will follow up on it. It's very reasonable to keep these folks monitored. Remember, medication reconciliation is really important. So 39% of patients were already on another medication that can prolong QTC. So maybe this guy forgot, you know, he's on Seroquel or he's on Slexo. Those are so many people are on those meds, and they both interact and prolong the QTC. We're going to focus on normalizing the potassium. That's a big one. A lot of times you can resolve those EKG abnormalities if you normalize the potassium. And what I've learned, you know, in terms of the medication reconciliation, some patients just like, I have a pregnant patient whose EKG was abnormal. They were on a higher than average dose, and their QTC was pretty prolonged, but they wanted to increase. And I said, well, are you taking any other medications? Oh, no, I'm not. But I had in front of me this paper from their OB, and it said metoclopramide. And I said, oh, are you taking a medication for nausea? Oh, yeah, I am. I forgot about that one. I'm taking it 4 times a day. Well, guess what? That prolongs your QTC. So sometimes, you know, we got to dig a little more. We have to like look at those refill histories in our EMRs and really see what people are. And then, you know, always repeating the EKG is a great idea. You know, if you do all these other things and you kind of minimize their risk of having a prolonged QTC and you repeat it and it's still greater than 500, you know, at that point, I think it's reasonable to consider some adjustment to their methadone dose. But remember, the methadone from yesterday is still going to be there, right? It's slow on, slow off. So in the outpatient setting, so for example, at the methadone clinic, if a patient misses multiple medicating days, there's an automatic protocol where their dose is decreased. So if they miss 2 or more days, they are decreased by a percentage of their total dose. And usually it's a 10% decrease. So we, you know, when people say, well, I'm going to cut their methadone dose in half, that's like a big decrease for patients who are otherwise stable, and they're going to feel it and they're going to feel bad. So, you know, it might be reasonable, instead of slashing that dose, to decrease it a bit, see what happens, you know, keep them on telemetry, talk to your friend in cardiology. And then, you know, at some point, if you say you decrease it just a little bit and their QTC looks better, maybe their QTC is now 495. Okay, it's better than 543 or whatever it was before. It's really important to have these conversations with the patient. So a lot of patients will be able to say, okay, you decreased my dose a little bit. I feel okay at this current dose. I think I can handle it. I'm not going to relapse. You know, I'll be all right. Some people will say to you, listen, I can't overdose again. I've done it too many times. I don't think I'm going to survive another overdose. I really don't want you to decrease my dose anymore. And so, you know, patients are adults, right? As long as they have the capacity to make those decisions, I personally think if we're discussing with them, we go into the details, you know, a lot of times I'll show them their EKG and I'll show them the numbers and really talk about what that means, why I'm worried, and, you know, kind of go back over their history of use disorder. And patients can really participate in that. And I think they really appreciate the chance where I say, I'm worried about your heart, but I know that your use has been a problem in the past. It's really a decision that we need to share with our patients. Like, I don't advocate making giant changes without somebody's input. And those are my slides. And I have my little MCSTAP slide up here at the end. I think we have a couple minutes if people have questions or want to put it into the chat.
Is there any chance you could email the slides from this presentation? I missed the beginning part of this.
I think Emily has my slides, and so she can email them out.
Thank you.
And I think also the talk was recorded, so if you wanted to watch the talk, that's an option too. I think they post, my recollection, correct me if I'm wrong, is that we post them onto the website like a little while after we do the talk so that you can watch them.
I just wanted to come off mute real quick. Mia, my name's Mike Gurney. I'm at the Bureau of Substance Addiction Services. I'm the open service coordinator there, and I just wanted to come off mute and say, if anyone has any questions regarding the OTP federal regulation changes, definitely reach out to me. I can put my email and contact information in the chat. Massachusetts is fully aligned with those changes. So there's been a lot of questions from providers and everyone else. So definitely feel free to reach out to me directly. We're taking a lot of questions from providers and kind of gathering all that. And we'll be offering some listening sessions over the summer and I think in July and August. So just wanted to throw that out there.
Yeah, that's great. There are a lot of changes, and it's funny because I think it's a little scary for some people, like, oh my gosh, and there's a lot of changes with take homes, and I think overall it's great, actually, and it's going to make being on a methadone clinic less of a barrier for patients living, a normal life, like being able to get back to their lives before. So it's exciting, but there are a lot of changes.
I have a question, Chris Shanahan. Actually, it's for Mr. Gurney. I'm so glad that you're here from BSAS. I've been under the impression that torsades is extremely rare, and that our fear as clinicians is way, way overblown. Does the state actually monitor the episodes of that? Do we collect data on that? Do we know what the actual rate of torsades is in the state by any chance?
I wouldn't be able to answer that question. It's nothing that, we collect. I work in the licensing unit for the Bureau, so perhaps it's collected somewhere. Trying to think of where.
I think it's very rare, Chris. Actual torsades is very rare.
I'm sure it is. I think that if the state published that, it would be very helpful for the clinicians that we're trying to convince that methadone is actually a safe option.
Yeah, it's hard to find that data. The only, when I went looking, I found that one paper from the Bronx that I thought was really nice because they looked at, but it's a different population than probably I see in my outpatient methadone clinic, right? It's a hospital population. And so even in that hospital population, they really only saw arrhythmias in 3% of the patients. So I see, great. So some people are putting questions in the talk too about the difference in risk with once daily versus split dosing of methadone. It is a great question, and I don't know if there's a strong evidence base to support. So I personally think that probably it's a little bit better if somebody already has like a known QTC prolongation and we know that they get it at a higher dose, to try a split and just, try it, follow up. I think we've done it. I'm trying to remember, like maybe once we had someone and we did split their dose and it made their QTC kind of acceptable. People are asking, would you just start the patient back up again on their methadone if they had torsades? It's a great question. I don't know if there's a right or a wrong answer. There is this case report out there in the literature that I don't know the name of, I don't know the author off the top of my head, where they had a guy who had a V-fib arrest in the hospital. He had a prolonged QTC, had torsades, had a V-fib arrest. They got him back and they Narcaned him on telemetry and then gave him a Vivitrol shot as a way to get him off of methadone. And I see somebody shaking their head. So my little group of buddies at my work, we've shared that article around and we're all like, can you even imagine our telemetry nurses? They would all instantly die if we tried to do that on the floor of a hospital. Not to mention how miserable, the patient would be miserable. I don't know that there's a right answer. I think, friendly local cardiologist, does this patient merit an implantable defibrillator? If they've tried all the other options for their opioid use disorder and methadone truly is the only medication that really works for them, I would really struggle to say to them, you can't use this medication anymore. I would probably do everything in my power to make it work for them but with the help from my cardiology colleagues. Yeah, and I agree. So someone else says it seems scary to resume the methadone. Yes, I don't think that it's not an easy discussion. Fortunately, this is rare. It's rare that it comes really down to this point where someone is like doing great on methadone and they have, they actually have torsades, and then you have to decide, discontinue or not. Oh, wow. So somebody's saying that in New Hampshire, they're in a private methadone clinic system and they were on 250 to 300 milligrams. There are some, yeah, we've had some transfers to our clinic from places in New Hampshire, and they're on extreme, 260, really high doses, higher than I'm accustomed to managing. There not seems to be any interest in decreasing the dosing in these clinics. How do you recommend handling these patients? And I'm sorry, this is someone who's an MFM specialist. So, I think the correct answer during pregnancy is that you don't decrease anybody's methadone. 300 milligrams is a really, really high dose that I would feel anxious about. And I think perhaps after the patient is done being pregnant, at that point, I find it's really interesting if you talk to enough patients who've been on methadone, they've been on and off of clinics over the years. And one of the things I always say to them is, well, what's a dose that you've been on in the past that felt good to you? And they'll say, I don't know, 120. And I also ask, well, what was the highest dose that you've ever been on? And some people will say, well, I was on 200 once, but I didn't really need that much. I didn't actually think it was helpful. And, I think there's a lot of stuff out there that's really interesting. One of our talks, one of our MCSTAP consultants did a talk for the Massachusetts Addiction Society, Jess Gray. She talked about methadone in pregnancy, and she talked a lot about how we measure the peak and the trough dose, and how maybe the peak and so we do this thing, peak and trough, where we measure the patient in the morning. They get a serum methadone level in the morning before they've taken their dose, then they wait 4 hours and they repeat the serum methadone level, and the peak trough ratio, if it's greater than 2, it means they're a rapid metabolizer. Well, there's another way of sort of measuring the metabolite of methadone that's maybe more accurate for some people. So some patients have these incredibly rapid metabolisms where you would think, wow, 250, that's crazy. But then you measure their peak and trough, and they're actually metabolizing a ton of that methadone. And they, by the end of the day, they feel awful. Sometimes those people need to split their dose so that they're, instead of taking 250 all at once, they're taking it in divided doses, and maybe that is helpful.
So Mia, it's Chris again. I just wanted to point out that it's the maternal and child, the maternal fetal health patients that were just, they got there. The reason they're on those high doses is because, their effective bioavailability, because they have so much more volume as they're in pregnancy. So it's not uncommon to find pregnant women that are on methadone, their doses going all the way up.
Yeah.
I don't think it's a big issue after they deliver to start tapering them back down. The clinic that I worked at, it wasn't such a big deal getting people down. I think that the split dosing is kind of getting mixed up a little bit too. I think it's partially to helps. Split dosing is mostly brought up with when you're talking about using methadone for pain, to kind of spread out the levels so that there's less pain. It's
but also
I don't
in
think
pregnancy, and then there are these people that are, and again, I like it because it's very quantifiable. Like, they are rapid metabolizers, and progesterone increases the metabolism of methadone. So as your pregnancy goes on, your progesterone levels are rising. And so many pregnant women, even pregnant women on low doses. So we have a pregnant patient in our clinic who's on 28 milligrams of methadone. And she has a split dose because if she takes all 28 milligrams in the morning, she feels sleepy in the middle of the day and then feels withdrawal in the evening. And she doesn't want to, keep increasing that morning. She didn't want to keep increasing the morning dose because it wasn't fixing the problem. So she's on some funny, it's like 18 in the morning and 10 at night or something like that, which seems, it doesn't seem like it would be consequential, but for her, it's absolute, like, she's like, I feel great. This is the perfect dose for me. But yeah, I mean, you're right. Methadone in the outpatient, we split the dose. It's every 8 hours, and in a methadone clinic, generally it's in the morning. But there are these people that, when we do those lab tests on them, which are a pain in the neck, by the way, those lab values are just so clear. Some people are way over the ratio of 2. I mean, their number is really high, and they just feel so much better when you split their dose. So a lot of people are asking for the slides. We can make sure that people get the slides. And then Kathleen, great question. I don't think I have it at the tip of my fingers, but I will try to find the citation for that paper that said the dose. I think, oh, actually, wait a minute. Let me go back. Let me go back before the cases. I'm pretty sure it's here. Journal Addiction Medicine, 2017, November, December, 489 to 493. Thanks, everybody.
Thank you.